Welcome to the Brain Injury Association of New York State's webinar, Getting Ahead of the Game, New Approaches to Concussion and Post-concussion Syndrome Evaluation and Treatment. I am Carla Giovaniello, Brain Injury Training and Services Project Director here at the Brain Injury Association of New York State. Thank you for joining us. Before we begin, a few housekeeping details. Questions can be submitted during the webinar via the question text window. The text box option should be visible to you on the GoToWebinar toolbar on your desktop. If you are having trouble viewing this option, please contact Citrix tech support at 1-800-263-6317. Again, that number is 1-800-263-6317. This number should also be visible on your toolbar. Dr. Leddy will do his best to answer questions in the order that they are received. Any questions he is unable to address may be submitted via email to the association. We will be recording this webinar session, and we do plan to post it along with the PowerPoint slides to our website. Our website is www.bianys.org. Information about contacting the association and viewing the webinar will also be provided in a follow-up email after the webinar has concluded. Before I turn the microphone over to Dr. Leddy, we're very happy to have him here with us today. Let us begin with a quick poll question to see who is in our audience. Please take a minute to answer the question. I'll give you about 10 more seconds just to make sure everyone's answered. It looks like we have a good deal of school-based medical professionals and non-school-based medical professionals in our audience. So there's some diversity there. We have some teachers, school administrators. It looks like we have a diverse group of individuals. I'm actually going to post those results and share them with you. I'm closing the poll now. So a lot of people fell into that other category. But I would like to thank you all again for joining. And it is with sincere pleasure that I introduce our webinar presenter for today, Dr. John J. Leddy. Dr. Leddy is a practicing clinician, active researcher, and instructor at the University at Buffalo School of Medicine and Biomedical Sciences. He is the medical director of the University at Buffalo Concussion Clinic, which is the first center in the United States to use a standardized exercise treadmill test to establish recovery from concussion and to use controlled exercise in the rehabilitation of patients with prolonged concussion symptoms. Dr. Leddy, good morning. How are you?
Good morning, Carla. I'm fine. Thank you. How are you?
I'm good, thank you. Thank you for joining us.
My pleasure. Am I ready to go?
Yep.
Well, good morning, everybody. My name is John Leddy. I work at UB, and I'm a sports medicine doctor, but I have an interest in concussion, and we've had a concussion clinic for a number of years here. And what I'd like to do today is just sort of introduce you to the way we approach concussion here at the University of Buffalo, and take you through that and answer any questions you might have. I'd like to acknowledge Dr. Willer and Dr. Baker. They're my colleagues in the clinic here. Dr. Willer is a world-renowned TBI researcher, and Dr. Baker is a very well-published neuropsychologist who works with us. I'd also like to acknowledge that we've had some foundation funding from the Buffalo Sabres Foundation and the Robert Rich Family Foundation to support our work, and other colleagues who've helped us along the way, and there's more that I don't even have listed here. Hope you don't mind, but there's going to be it's going to be hard to have a talk from Buffalo and not have a crack about the snow. The other thing I'd like to tell everybody is that we've developed a concussion management and research interest group in Western New York, where we gather people from the community on a monthly or bi-monthly basis to discuss concussion management research and ways to collaborate. It may be something that you'd like to consider doing in your region if you're so inclined. And we've also formed an upstate New York thruway concussion consortium in collaboration with the University of Rochester and SUNY Upstate at Syracuse. We'd like to include Albany in this. I just met the program director recently at that clinic. If others are interested in this, please contact me at the email address you see on the screen. Well, just to take people back to a little basic epidemiology before I move on, we did a study a number of years ago of 1 million high school students in Ontario, Canada, and found that 1 in 4 young people would have at least one concussion before they finished or left high school. Twice as likely among boys, in teenagers most often from sports, and in children, younger children, from falling on the playground or at home, etc. And this is probably an underestimate even of the number of concussions that are occurring yearly in the U.S. This may be only the number in sport, as it turns out, and not including non-sporting activities. So it's a very common problem, as you know. It's a public health issue. And it's good to go back to basic definitions sometimes just to orient us to where we are and what we're talking about. A concussion is a blow to the head that results in an altered state of consciousness, and that's important because it's represented typically by some degree of confusion after the injury. That is, people are dazed, may not know where they are or what the circumstances are for a while. May or may not have unconsciousness, and in fact, in the sporting situation, unconsciousness is distinctly unusual. This is more common in work or car accident injuries, but not in the sporting situation. There's almost always, not always, but almost always some level of amnesia, that is memory loss for things after the event, which is called post-traumatic amnesia, or retrograde amnesia, loss of memory for events leading up to the injury. And generally you can tease this out with a very careful history when you're talking to patients about the head injury they sustained. Now, what happens to the brain is really a movement of the brain tissue inside the skull. So it's this mechanical moving back and forth that damages the neurons, we believe. It's called diffuse axonal injury. This mechanical shearing or damage leads to a metabolic cascade of changes in neurotransmitters, neurotoxins, and other ions, etc., that results in the symptoms and signs of a concussion. Now, I don't think this little graphic's going to work, but imagine the brain in here just shaking back and forth in the skull, and that's the initiating event in the series of events that subsequently produces signs and symptoms of concussion. Now, this is a busy slide. You'll be quizzed on it at the end. I'm kidding. But this is kind of a classic slide from the original animal work that was done in rats, where they give rats concussions, and then they measure via little dialysis techniques different changes or changes in different substances in the neurons, such as potassium ions, calcium ions. This is the amount of glucose the brain is using after injury to try to heal itself. You get a buildup of something called lactate acid or lactate, which you build up in your muscles when you exercise intensely. Same thing happens in your brain. In fact, the brain can use lactate and glucose for fuel, and that's the only two substances the brain uses for fuel. At the same time, all these things are changing, and this is over a period of minutes to hours to days. You have a reduction in what's called cerebral blood flow. So the amount of blood flow going to your brain during this critical time is actually reduced. And this has been shown to occur in humans as well. So you can think of a concussion as an energy crisis in the brain. All these different ionic changes are happening. There are changes in neurotransmitters like glutamate. And so the brain is actively trying to repair itself, yet it has a reduced blood flow. So a concussion is almost like a angina in your heart. There's a demand that exceeds the flow available to it. Now, most people recover from a concussion with, at least from one concussion, we think, with few consequences that may be changing as we learn more and more about concussion in the next 5 to 10 years. But anyway, we think most people recover, at least in terms of their signs and symptoms. But anywhere from 5 to 10% have symptoms that persist, and we call that post-concussion syndrome. As we'll discuss later, syndrome may not be the best word for this because it's not just one clinical entity, it's several. We really don't know the cause for persistent symptoms in some people. We think we know it now better than we used to, but this is still a big area of potential research. And in terms of treating post-concussion syndrome, there's really no good evidence-based treatment for it. That is, no one's done a big randomized clinical trial in people with post-concussion syndrome for the effectiveness of different types of treatments. Up till recently, rest and antidepressant medications were the most common modalities used to treat these people. They were told that the symptoms mean that they have to continue to rest and not make them worse. And since lots of people get depressed when they have post-concussion syndrome, antidepressants were prescribed. There's very little evidence, though, that they're efficacious. Now, there are lots of symptoms of concussion, and I know many of you know this very well, but I just wanted to put them up here. Somatic means body, neurobehavioral, again, the things like irritability, sadness, depression, sleep disturbances, and then the cognitive symptoms, feeling slowed down in a fog, and difficulty concentrating and remembering are almost ubiquitous. So we know there are lots of symptoms of a concussion afterward: headache, balance problems, very common, sensitivity to light and noise, very common, visual trouble, etc. But I wanted to ask a question at this point, whether people are aware that there are also signs of concussion, not just symptoms. Carla?
Everyone should see the quick poll question now. There are common symptoms after concussion, but were you aware that there are also physiological signs of concussion? Please take a minute to answer the question. Thank you. I'm going to close the poll now and share the results. Dr. Leddy, could you see the results on your screen?
No, I can't.
We have 84% answered yes and 16% answered no.
Oh, that's pretty good, actually. You are a fairly sophisticated group. Should I continue?
Yes, you can continue. You're all set.
Okay. Well, that's right. There are not just symptoms of concussion, but there are signs. And a sign means something you can observe or measure. And concussion really is what we describe as a physiologic problem or phenomenon. And we know that for several reasons, not just the fact that there's altered balance, et cetera, that you can measure, but researchers have looked at this in terms of changes in what we call the autonomic nervous system. The autonomic nervous system is responsible for the fight or flight response when you're scared, and it's also responsible for your ability to go to sleep, things like that. So what happens after concussion is that we have an altered balance of the autonomic nervous system. The sympathetic system, which is responsible for the fight response or flight response, takes over. And the parasympathetic system, which is responsible for being able to feel calm and sleep, et cetera, is diminished. And I'm not going to go into what these really mean, but what these studies have shown is that there are changes in blood pressure and heart rate that you can measure when you stress someone with a concussion with exercise versus non-concussed control patients. There are also changes in cerebral blood flow, as I described in animals. And in kids, this study came out just recently. Its cerebral blood flow is reduced at rest in about 30% of the kids, even up to a month after the concussion. And we have some data from our lab showing that it's actually increased when we exercise people at low levels. So there are changes in your cardiovascular response to exercise after concussion, and that's reflected in the data. Now, what most people do now in terms of returning people to play after they've had a concussion is follow a graduated return to play protocol that came out of several expert consensus statements on concussion in the last decade. The last one was in Zurich, Switzerland in 2008. And this is what most people follow after the student reports being asymptomatic. And at first they're resting until they feel better, and then we have trainers or coaches or gym teachers try to progress them through light aerobic exercise to see if symptoms come back, and then sport-specific drills. Then if it's a contact sport, non-contact training drills, finally full contact practice, and then return to play. This is sort of a general guideline. We don't have any evidence-based data on what the best way to do this is. There are some suggestions for it. But basically, it's reintroducing activity in a graduated fashion, and it makes good sense to follow this. The problem, I'm going to get back to this in a second, is what happens to the person who is not reporting that they're asymptomatic at rest. Post-concussion syndrome is generally conceived of as a form of what's called mild traumatic brain injury. If you look at the way this is defined in the literature, it differs. It used to be defined by something called the Diagnostic and Statistics Manual 4 document as a head injury that produces significant cerebral concussion, which meant cognitive deficits on neuropsychological testing, 3 or more symptoms more than 3 months, interference with function, and excluding other diagnoses. This is largely a psychological or cognitive definition of post-concussion syndrome. A number of years ago, the World Health Organization came out with a more liberal, let's say, definition that after head injury, if you had 3 or more symptoms lasting more than a month, you classified yourself as post-concussion syndrome. Now, this has been looked at by researchers, and there really is little concordance between these 2 criteria. That is, the DSM criteria are very restrictive, whereas the WHO criteria seem to be rather liberal, and they don't really help us define PCS very well, it turns out. And what this means is that there's serious weaknesses if you just take a symptoms-based approach to trying to diagnose post-concussion syndrome. I mean, it's all we've had for a while, but it's hard to go or to use symptoms alone because symptoms are very nonspecific, and it turns out that the average person without concussion who you give a symptom scale to and ask him or her, do you have a headache, are you tired, are you irritable, are you having trouble concentrating? If you go through a list of 22 signs or symptoms, most people are going to check off 2, 3, 4, 5, or 6 of them on any given day. So the concept of being asymptomatic at rest is not without difficulty. Also, because of all of the publicity around concussion now, some athletes we find just get very focused on their symptoms, and it's hard to even recognize whether or not they're asymptomatic. So again, there are lots of problems with just a symptom-based approach to defining post-concussion syndrome.
Dr. Leddy, I apologize. We do have a question from the audience. Someone asked, do you use neurofeedback, brainwave biofeedback in your treatment of the long-term sequelae of concussion?
We do not. We use, well, I'll talk about this later. for persisting cognitive issues, we use cognitive therapy and cognitive behavioral therapy, but we have not moved into any type of neurofeedback yet. I think that's an interesting method, however, because probably with methods like neurofeedback or meditation, etc., what you're doing is you're actually trying to change that balance of the autonomic nervous system back toward parasympathetic, increasing parasympathetic activity. So I think methods like that are actually useful. To my knowledge, they haven't been studied yet, but I think it's an interesting area that requires more research. Going back to the return to play guidelines now. Remember, the recommendations are not to do anything until your symptoms go away. The problem with athletes is that if their symptoms don't go away within a few weeks, they start to get deconditioned, okay? And that is a problem, especially for athletes, because it affects their performance, but it also affects their mental state even more. And what we're finding out is that, as I'll discuss in a little while, concussed athletes definitely should avoid exercise for the first 2 to 3 weeks after injury. I mean, this has become fairly standard treatment. We don't know the exact duration of time that rest should be employed, but the animal data suggests at least 2 weeks. But we're starting to appreciate that after this period of time, exercise is not only useful but also beneficial, and that rest may be actually detrimental at this point. So this is the time for the next poll question.
Please take a minute to answer this next poll question. Are you aware that you can safely exercise someone with post-concussion symptoms at 3 weeks after injury? Please take a moment to answer. Thank you. All right, I'm going to close the poll. It appears that 55% answered yes and 45% answered no.
Okay. Again, I think that's pretty good. What we've based some of our research on is the fact that if you concuss a rat, hit a rat in the head with a baseball bat, and then put the rat on a treadmill, what this graph shows is that before 2 to 3 weeks, the cognitive performance of the rat is actually worse than when you compare it to the baseline level. But after 2 to 3 weeks, if you exercise the rat, their cognitive performance, finding their way through a maze, et cetera, gets better. And this has been research done by the same group that did all the original animal research in the metabolic cascade after concussion. So it's the leading group in the world that's done this type of research. So the timing really of exercise after concussion is key. So I think what I'm leading up to is that we're trying to take the animal research and the best aspects of the return to play guidelines for athletes who have post-concussion symptoms and meld them. So the positive aspects of these guidelines are that exercise to voluntary exhaustion without exacerbation of symptoms seems to be a key element here. That is, that return to play cascade or progression indicates that if you can do light level exercise and not have symptoms, a moderate level of exercise, not have symptoms, sport-specific drills and non-contact practice without symptoms, and go all the way up to the physical requirements of your sport without symptoms, then you're ready to go back and play. And again, these guidelines are consistent with the research I talked about, in that there's this physiologic imbalance in at least some patients with post-concussion syndrome manifest by altered autonomic nervous system balance, reduced parasympathetic response, and altered cerebral blood flow. Now, one question the Zurich conference asked in their document was, is provocative exercise testing useful in guiding the return to play decision? And we think that if you accept the notion that concussion and at least some PCS syndromes may represent an imbalance of a physiologic nature, then one must accept that provocative exercise testing might be useful. And so if you were to poll concussion centers around the country, I think you'd probably find out that they have different philosophies. Some have very neurocognitive-based types of assessments, such as University of Pittsburgh, where computerized neuropsychological testing was essentially developed. And if you go to a concussion clinic there, you will see a neuropsychologist and have impact testing, and that's their approach, and that's a very popular one, and one that they've well published on. Other centers take a more psychological approach, again, to post-concussion symptoms, treating patients with counseling, antidepressants, et cetera. That's another approach. Here at UB, though, we take a physiological approach. Again, it's just our way of trying to deal with sorting out the cause of the symptoms and trying to help people recover. So again, I'll go back to we get a history of concussion, and we define those who have persistent symptoms as having 3 or more signs or symptoms lasting at least 3 weeks. And we then define physiologic post-concussion syndrome as exacerbation of symptoms with provocative exercise. So we're combining here the strengths of the symptom-based approach, but we're trying to introduce a physiologic concept that's consistent with the Zurich consensus conference guidelines. And so for the doctors or nurses or healthcare providers in the audience, what we try to do is, during the history, get an idea of the symptoms at the time of the injury, the first few days after the injury, and the current symptoms they're experiencing. The other thing you want to get an idea about is, had they had prior concussions and symptoms before the recent injury, and what other associated medical conditions do they have? There's some consensus now that having a history of migraine headaches, learning disabilities such as ADHD or premorbid depression may actually predispose patients to concussion, and if not, at least prolong or delay their recovery. We then do a physical examination because if we're going to exercise test someone, we have to make sure that their balance is okay and that they're cardiovascularly they're able to withstand exercise. We also examine the cervical spine, and I'll talk about that more later. If people are reporting dizziness, especially with standing up, we do check orthostatic vital signs. You'll find that some people have such autonomic dysfunction after head injury that their blood pressure drops and their pulse rises when they go from a lying to a standing position, and they report dizziness or almost passing out. Test I'm going to discuss today, we've now done this in more than 200 and probably 300 now individuals. Some of them had multiple treatments or testing, and we found that by and large we've been able to test these people without any incident, except that some of them will report increased headache several hours after exercise, but they're better by the next day. We've also studied this.
Dr. Leddy?
Sorry, is there a question?
Yes, we actually do have a question from someone in the audience. They would like it if you could address the predisposition to symptoms again. I'm guessing
okay.
when you were talking about migraines. And
yes. It seems that we certainly have observed this, and maybe others in the audience who treat concussions, is that it's not all that uncommon to see people with delayed or prolonged symptoms, delayed recovery, that have had a history of migraine headaches before, or their post-concussion headaches are migraine in quality. People with ADHD, again, seem to have more trouble recovering from concussion. That may be because we define it largely by symptoms, and symptoms of difficulty concentrating and remembering are common in those with such conditions even before having a head injury. And again, depression prior to, but certainly after head injury seems to be associated with delayed recovery. So these conditions that I've listed here may not only predispose athletes to sustaining a concussion. Again, we don't know that for sure yet, but people are raising that issue. But also, it seems like it delays their recovery.
Dr. Leddy, can OCD be a new symptom of post-concussion syndrome?
Can OCD be a new symptom of post-concussion syndrome? I think it's possible. I don't recall seeing that. I think it's probably in the same category as maybe ADHD and depression in terms of having some sort of psychiatric or psychological diagnosis. So I wouldn't be surprised if that could develop after concussion, although personally I have not seen it. Going back to the research we've done on our exercise testing, we wanted to assess something called reliability of the test. If you give a test, you want to know that it's reliable when you give it more than once in terms of producing the same results. And is it reliable if other people are doing it? And we found that the test had good reliability if you did it several weeks apart. In fact, it was better than the results when you look at the reliability of impact computerized neuropsych testing. And that it's reliable if you have different types of people looking at the test, that is doctors, trainers, nurses, chiropractors, etc. So I've discussed this before in terms of the history we get, so I won't go through that again. I hope this little video plays. I don't know if it's going to, but it's I'll try to give it a few seconds here. I'm not seeing it on my screen. Carla, are you?
No, it's just green.
Yeah, I don't think it's going to work. Anyway, it was a picture of a football player getting tackled and hit in the head. But what you really notice in the video is that his neck gets severely twisted at the same time, and it just is a reminder to everybody that the neck holds the head up, and usually in an injury that's going to cause concussion, you're going to get some trauma to your neck. This is the protocol we use. Again, I'm not going to go through this in detail. It's in our paper and it'll be on the website. But we use what's called a modified bulky protocol. It's a very slow and safe way to increase exercise intensity. That's used in people with cardiac disease and orthopedic problems. And again, we've adapted it to our types of patients, and that's listed here. Again, it's on the website, and you can always send me an email if you'd like to get more specific information on how you do the test and the protocol we actually use. We call it the Buffalo Concussion Treadmill Test. And we measure heart rate, blood pressure, and rating of perceived exertion throughout the test, and ask them to tell us when they have symptoms and if they need to stop. Again, athletes are used to pushing through symptoms and playing with pain. And we don't want them to do that during the test. We want them to tell us exactly what they're feeling. And we always have a second person available and the first time we're doing the test in case there's difficulty with balance on the treadmill. This test we think can be adapted to the cycle too, and that's something we're looking at. Now, I don't think I have a series of videos that had I been giving a talk in an auditorium that you could see, but I don't think it's going to work for the webinar, and that's too bad because they're pretty instructive. But anyway,
we can try to post those on our website as well with your slides, if that's okay, Dr. Leddy.
Yeah, sure. Yeah, that'd be fine. But what happens is, as athletes are exercising on the treadmill, and we increase the grade of the treadmill 1% per minute, so we're increasing their heart rate and their blood pressure. And those who have this ongoing problem with autonomic control and control of cerebral blood flow, what we've observed is that fairly early on in the exercise, for someone who's in good shape, they start to have problems with controlling the blood flow to their brain during exercise, and their head literally fills up with blood, and they say things like, "It felt like I have my hat was too tight," or "I feel like my head's filled up," and they typically get a headache and dizzy, and they have to stop. They can't really go on, and they don't, they start to look kind of in distress, so we stop them right away. And only is there really occasionally an exacerbation of their resting symptoms. That is, they're not reporting confusion or trouble with memory or photophobia, trouble with sensitivity to light. They report this headache and dizziness and their head feeling full. Now, there's a little bit of clinical skill in doing this test and interpreting it, because you can get symptoms on an exercise treadmill test just from doing the exercise itself, especially if you haven't been doing anything for 4 weeks, 8 weeks, 12 weeks. But what happens with this physiologic dysfunction is that it occurs earlier in the test, at an earlier rating of perceived exertion, and there are more obvious signs of distress. People who exercise on a treadmill and go all the way up, I mean, they're going to get tired and they might get a bit of a headache at the end of it, but that's because they're simply exhausted. Again, I don't think this is going to, well, I can see it. Can anyone see it there?
It looks a bit choppy. Someone just wrote it's working fine.
It is working fine. Okay. Can anyone hear it? There's supposed to be audio with it.
I can't personally hear it. I could see it.
Maybe you could poll someone and see if they can hear anything.
No, I believe people cannot hear it.
But is the video coming through for people?
The video is coming through, just no audio.
Okay. Well, I'm going to just show this one then, because this is actually not a bad instructor. So this is a soccer player who had a concussion. If I recall, it was about 5 or 6 weeks before, and he's had ongoing symptoms, has not been able to exercise. And so we've got him on the treadmill here, and what you can see in the lower left corner is his blood pressure and heart rate are being recorded continually. We do the heart rate with an actual polar heart rate monitor because that's more accurate than the blood pressure cuff. The cuff also has a heart rate, but it's not as accurate. And what Scott, the physical therapist here, is he's raising, and right at that point, he reported that he had a headache and he felt like his head was going to explode right when he grabbed his head there. So we stopped the test. And again, what this means is that he had a fairly sudden onset of his symptoms after not a whole lot of time on the treadmill. And so we would call that a physiologic threshold. He had to stop because I think he just couldn't control the blood flow to his brain during exercise. This looks pretty choppy to me. Is that how it's coming through to you too?
Yeah, it's a little choppy, unfortunately.
Can you poll someone and see if it's coming through better? If not, I'll just move on from it.
People are reporting it's a little choppy.
Okay. That's probably not going to be useful then. I'll just move on from this, but this athlete was further along in his recovery than the previous athlete. He gets to a threshold, but not till later on in his exercise when he's about at 80%, 85% of his maximum heart rate. And so what we could tell him was that, look, you still have some physiologic dysfunction, but you're close to recovery. And that's true. He was able to recover faster than the prior athlete. The next one, let's see if it comes through. Again, I apologize for the technology, but No, that's the same guy, sorry. The next one is a young lady who, again, had post-concussion symptoms. But if you can see her, she's exercising, and she actually goes, her heart rate is up, in the 180s there. She's getting, pretty good exercise in here, and she reports a bit of a headache at the end, but she's smiling and she looks good, and she never develops this threshold that we see. So this is someone who, if she had a concussion, we think the physiological part is recovered, and the headache may be from her neck or some other issue. But we told her that she could go back to exercising aerobically at least, and we gave her an exercise prescription to follow. So the test helps us with the differential diagnosis and also with determining how far people have recovered. So just to review, post-concussion syndrome, or physiologic post-concussion syndrome, I should say, is represented by having symptoms, but also this symptom exacerbation with exertion early on in the treadmill test. I'll talk about the neck a little bit more, but cervical headache or cervical strain usually produces a headache and or dizziness later during the test. And in fact, what we find with cervical headache is that they get a headache early on that gets better. It doesn't stop them. It gets better during exercise, and then it may reappear at the end when they're working as hard as they can. And then we confirm this with a very careful neck exam. The differential diagnosis, if it's not physiologic post-concussion syndrome or cervical issue, which is the most common reason that they would have ongoing symptoms without physiologic dysfunction, then what we're finding is that lots of people have vestibular issues, and in association with that, ocular issues. They have blurred vision or trouble accommodating. Again, they may have this migraine phenomenon. They may just have an anxiety reaction to their situation. And we're also finding a group of people that have persistent cognitive issues, especially when they return to work or school, even though they can exercise and not get any symptoms. And this is a group that other people are reporting on too, and is something we want to study. But then you refer them for specific treatment of these issues: vestibular rehab, which also helps their vision, cervical rehab, treatment of migraine, maybe counseling, etc. This is, I think, the time for the third polling question.
Okay, I'm going to pull that up now. I did launch it. Please take a minute to answer the question. Thank you. I'll leave about 5 seconds or so before I close the poll. All right, it appears that 66% answered yes. They are aware that a cervical injury can mimic many of the symptoms of concussion, and 34% answered no.
Okay. Again, I think that's pretty good. I don't think a lot of if you polled a lot of the doctors around New York State, we'd get that good of a response, actually. But that's absolutely true, and we'll talk about that more in a minute. Going back to how we treat this PPPCS, or physiologic post-concussion syndrome, if we identify this threshold that we think is physiologic, we then have the athlete exercise between 80 to 90% of that threshold heart rate. Again, there's a little clinical judgment that comes into that. 80% for most people, or high school athletes. If we have a high-level college or pro athlete, we'll go to a little higher level, only because we think they can take it. 20 minutes a day, initially with someone else present, just to make sure they're doing okay. And then we tell them that if their symptoms are particularly bad that day, don't exercise, or if they get worse during exercise, stop. But most people can do this because they've proven on the treadmill test that they can get to this heart rate level without exacerbation. And again, they may experience a temporary increase in symptoms later on that day, but by the next day, they should be ready to do it again. And even in Buffalo here, or if people come from out of town or out of state, what we will do is every week to two, we will see how they're doing, and we will increase the exercise heart rate 5 to 10 beats per minute, and then reassess every 1 to 2 weeks and progress it that way. And it really, it depends on how they're progressing as to how long it'll take to recover. And once the individual can exercise to essentially exhaustion and near their maximum heart rate, and usually once they can get to 90–95% of their maximum heart rate without symptoms, we deem them physiologically recovered. Now, some of them may still have some minor cognitive, that is, they may have a little difficulty concentrating in school, or sometimes if they have visual disturbances, they have some trouble reading. If they still have some balance issues, this will not respond to the aerobic exercise. If they're minor, they can usually return to sport. If they're more symptomatic, they need ongoing either cognitive, vestibular, or visual rehabilitation. So again, not everybody is the same with post-concussion syndrome. You have a wide variety of signs and symptoms, and every individual is unique. But at least from a physiologic standpoint, once we can get them exercising fully without symptom exacerbation, they're at least ready to try to return to sport. These other issues may be more prominent in some patients and have, and therefore they have to have specific ongoing rehabilitation. Interestingly enough, most patients will not have any changes in neuropsychological test performance through this whole process. And it's been shown in post-concussion syndrome that neuropsychological testing is not really a good way to follow them. Some patients can return to play if they are physiologically recovered, but if they've had too many concussions or, again, persistent vestibular problems, we advise them not to return to play. And again, that's a very individualized assessment. So right now, I'm going to diverge into a little bit of the research that we have and then finish up, if that's okay. And we think that the exercise test is a valid approach to the evaluation of post-concussion syndrome, and that it helps us in the differential diagnosis of these disorders, as I'll call them from now on. Some of these patients have ongoing problems with this regulation of blood flow, and we have some evidence to support that. And again, we've published on the fact that this is safe in concussed patients with prolonged symptoms, and it's a reliable test in terms of retest reliability and inter-rater reliability. This is a paper we published earlier this year on how the test helps us with the differential diagnosis of post-concussion disorder. And I think this is all coming up at once, but let's see. Yeah, I'm sorry. When we first published this paper and 91 subjects, 2/3 of them, I'll say this whole blue area, had what we called physiologic post-concussion disorder. 1/3 of them did not. That is, they exercised to exhaustion without symptoms. And most of those had a neck source as their as the source of their ongoing symptoms was a neck injury. We're looking at more of our results now in twice this number of people, and we're finding that at least half of them have a cervicogenic source for their ongoing symptoms. That is, half or more of these people are exercising to exhaustion. And when we measure their cervical sense of proprioception, that is knowing where your head is in space at any one time, and carefully looking at their upper cervical spine, we're finding a lot of these patients' symptoms are from the neck. So my advice to clinicians is if you have someone with long-standing symptoms after a concussion, don't forget the neck. It can be the cause of symptoms in more than half of your patients. But others, again, migraine, depression, post-traumatic stress disorder, again, in people who are having flashbacks about their injury, again, get them into counseling. Visual trouble, all these contribute to the ongoing symptoms in post-concussion disorders. And we try to use the treadmill test to help separate out the physiologic, purely physiologic, from the non-physiologic, but fully realizing that some patients have a combination of disorders. I told you about this cerebral blood flow, and I'll just show this briefly, but in a small number of athletes, we measured cerebral blood flow before and after we treated them with exercise. And this is a normal line for how your cerebral blood flow increases as exercise intensity increases. So here you have increasing exercise intensity as a function of increasing cerebral blood flow. The normal people are like that. Before treatment, the 3 soccer players had high cerebral blood flows during exercise, so this is why they had to stop. They got a headache and they had to stop exercising at these points. After treatment, their cerebral blood flow came down to more normal slopes and levels, and they were able to go to a longer period of time. That was, okay, there we go. That's the control level in the post-concussion before treatment and then after. Again, a small number of subjects, but evidence of some physiologic dysfunction. And I apologize if this is redundant for some people in the audience, but recently we did a study using a functional MRI. Functional MRI takes a picture of your brain that you see with a regular MRI, but superimposes neural activation on it by looking at the level of oxygen saturation in the blood. And what you can do is you can take people with concussion and compare them to non-concussed people and give them a small cognitive task to do in the scanner, and then measure them before and after a period of time. Now, this has been looked at by other researchers in the past. Generally, what they have shown is that people with post-concussion symptoms have this sort of global increased neural activity while doing these cognitive tasks that you don't see in non-concussed people. So we did a small study where we took 2 groups of post-concussion symptom patients, gave them exercise like I described before, and then we took a placebo group and just had them do stretching, and we compared them to a healthy control group. And again, the exercise group did what I described before, where they exercise at a percentage of the heart rate on the treadmill test, 20 minutes a day, and we increased their exercise as their performance improved. The stretching group just did some stretches every day with a heart rate monitor on, just like the other group did, but they were only achieving a very low heart rate on the heart rate monitor because we didn't want them to have a cardiovascular training effect. And then both groups versus the healthy controls had this fMRI exam at time 1 and time 2 prior to and after whatever intervention they had. The healthy controls didn't do anything during that time. This is an example of the cognitive task. They were given a series of numbers in the scanner, and they had to press a button saying whether the result was greater than or less than the value of 5. And if we look at the groups before any type of intervention, the people with post-concussion syndrome really had the same number of symptoms, and that is the same exercise capacity. They achieved the same heart rate during that treadmill test. And what we found was they had no differences in their ability to perform that cognitive task. So all the groups actually performed the same on that task in terms of their speed and accuracy at time 1 before intervention and even after time 2. So the task was such that there was no difference in performance. But if you look at what happened with exercise and symptoms, it was a little different. The group we had exercise predictably improved their exercise tolerance significantly by the end of the 12 weeks, whereas the stretching group did not, because they were not getting a cardiovascular effect. In conjunction with that, the exercise group had a significant reduction in the number of their symptoms by the end of treatment, and this is now at control levels of reporting of symptoms, whereas the stretching group had a non-significant decline. And so there was a big difference in their symptoms by the end of treatment. And when you look at these fMRI scans, if you look at the healthy control people, again, this is taken during the math task as they do it in the fMRI scanner. When you look at the symptomatic people, again, you see a generalized increased level of activation here and here versus the healthy non-concussed people. And then when you pool all the data from the individual scans, what we find is that when you look at the healthy controls versus the symptomatic people, all 8 of them, there was a difference in their brain activation patterns when you look at the combined data in certain parts of their brain. This is actually the cerebellum, the cerebellum down here and a part of the brain called the cingulate gyrus. And these parts of the brain are involved in memory and attention, it turns out. So even before any kind of intervention, we found that healthy people did differ from the concussed people. And then after treatment, we found that the people who were given exercise did not differ from the healthy controls, but the people who had the stretching placebo condition were different from the healthy controls at time 2. They differed here, here, and here. Some of the data are not what we call corrected for multiple comparisons, but there were differences in the stretching group versus the healthy people after 12 weeks of essentially just stretching. So we hypothesized initially that the symptomatic subjects would have different fMRI metabolic activity compared with the controls during this arithmetic task, and that was confirmed. We hypothesized that the people who got controlled exercise treatment and recovered would not differ from controls, and that was confirmed on the scans. And that the exercise-treated people would show more improvement than the placebo stretching treatment, and that was confirmed too. Again, this is a small study. It only suggests the possibility that we may be seeing actual changes in brain function with exercise. And it could be that the results were there because of the small number of subjects, or it was just coincidental. And it really only applies to those who we define as having the physiologic post-concussion syndrome, not anyone with a neck injury or a migraine headache, et cetera. So acknowledging there are significant limitations to the study, it's still interesting and points to further study. So to conclude, we think that some people with post-concussion syndrome symptoms or post-concussion disorder may be related to abnormal regulation of their cerebral blood flow, and that the treatment we give them may restore this cerebral blood flow to normal levels, at least as indicated by this fMRI activation pattern during a simple cognitive task. So I think I'm concluding now. We use the treadmill test in those who are symptomatic for more than 3 weeks. We think it helps us in the differential diagnosis of post-concussion disorders, specifically to separate out those who we define as physiologic versus non-physiologic post-concussion syndrome. The exercise rehabilitation we use for the physiologic PCS patients is safe. It's effective, at least in a small study that compared it to resting alone, and it's reliable. And then if you can, again, separate out these disorders, you can direct specific treatment to the other post-concussion disorders, such as the neck, the vestibular system, migraine headaches, et cetera. And some patients will have combinations of disorders. So again, we're moving past the definition of post-concussion syndrome into post-concussion disorders. The physiologic PCS is, we think, a continuation of the same dysfunction that we see acutely after concussion, and we define it as a symptom exacerbation threshold at a low or submaximal level on that treadmill test. And we treat with progressive controlled aerobic exercise. It works especially well in athletes, it seems to. But when you move into the non-physiologic post-concussion disorders, again, no symptom threshold on the treadmill test. The cervicogenic cases, which are very common, we treat them with strengthening of the muscles, range of motion if their motion is reduced, and what we call proprioceptive training with the physical therapist. This is very important. This is almost always disturbed in these neck-injured patients. Vestibular and ocular symptoms usually go hand in hand, and we treat them with vestibular rehabilitation. That's a whole specific method of rehabilitating these patients. Migraines are treated with specific medications, and if there are more emotional or anxiety or post-traumatic stress disorders, then we can still have them exercise. It's safe to do, but they will need counseling and sometimes medications. And again, a combination of the disorders is not uncommon. Very often cervicogenic and vestibular go hand in hand and require treatments directed at both disorders. This is a little sort of just progression through the way we separate out people with acute concussion from those with post-concussion symptoms, and how we approach the evaluation and treatment. So this will take you through that. It'll be on the website. Initially, we use rest and information. If the symptoms resolve, that's great. They go back to play. After a graduated return to play. But in some people, we will do a treadmill test to make sure they're recovered. They may or may not have had neuropsychological testing. If they do well and can exercise to exhaustion, we return them to activity or to play in the case of an athlete. If they fail this, or they have very abnormal neuropsych test results, and they compared to baseline and the centers that use that, then they're given more time to recover. And then, at least in Buffalo, we would do a treadmill test. If they pass that, and if they've had neuropsych testing and it's normalized, then we return them to activity. If they fail that again, however, then we will move into this aerobic exercise rehabilitation and return them to activity when they're asymptomatic during peak exertion. If their symptoms are persisting 3 weeks or more, we will do the treadmill test. And again, passing means they do not have a threshold. Failing means they do, and they go into aerobic exercise. If they pass, then we consider alternate diagnoses for their symptoms, the neck, migraine, etc. And we return them to activity after we treat their specific problem. So this may help you in terms of the progression you want to think about in evaluating and treating people with prolonged symptoms. And I think that's it. Thank you for your attention, and I'd be happy to answer any questions.
Dr. Leddy, we do have one question, and thank you again for presenting today. The question that I have is, do you support neurocognitive testing as one more tool to assist a clinician or ATC to determine a child's status, along with a physical challenge like the treadmill? The treadmill does not seem to give a picture of cognitive impairment, that's what was written.
Yes, I think neurocognitive testing can be useful in certain circumstances, and where I think it's useful is in people who are reporting persistent cognitive problems. I don't use neuropsych testing acutely after concussion if someone is still symptomatic from the concussion, if they have a headache or they're reporting photosensitivity, etc., because the headache itself will affect the results. So I think if you're going to use neuropsych testing, if that's the way you're going to go, it only makes sense to use it after the acute concussion when people are reporting their symptoms are better. It's best to have a baseline to compare to the athlete to him or herself. But we've done a study where we showed that lots of people who were able to return to full exercise capacity after concussion still had some minor abnormalities on the computerized test. And we're not sure what that means. It may reflect different pathologies, and it may help predict who might have some trouble in school. So I think it's a question of how you use neuropsych testing and when. If you're going to use it, again, don't do it while people still have a headache or feel foggy, because that will affect the performance. It's really only useful once they're reporting that their symptoms are significantly reduced. I myself don't feel that it's a particularly reliable indicator of when someone has recovered from concussion, but I know they are widely used, and if you're going to use them, then I think you have to be well trained in how to do the test. The test has to be done in the same conditions after concussion as it was given before. And I think the best use of that test is still not clear to me. But I know that lots of kids are getting baseline tested now, and at least it's helping to change the culture surrounding concussion. That is, we're looking for objective data to tell us when student athletes have recovered, because the symptom approach, as I think I illustrated, is flawed, is difficult. Do we use neuropsych testing sometimes here? Yes, we do. Especially if someone comes in having had a baseline. I think it is one tool, but here at Buffalo we use the physiologic approach more to determine when someone's ready to return to play.
Thank you, Dr. Leddy. We do have another question. What about people who have developed mobility issues? What are some ways to assess that?
Not sure I understand the question. Do you mean inability to walk and do exercise?
I believe Ben asked the question. Ben, if you could provide some clarification. Thank you. In the meantime, we do have another question. We have a registered nurse at a high school of 500 students. She says they've documented 40+ concussions this year. They do follow the Zurich guidelines and utilize the impact test as a tool as well. The great majority of students progress well. 2 students, however, are under the care of a neurologist for prolonged symptoms. At this time, do you feel that it is safe, that this is a safe model, knowing that if the student is symptomatic after 3 weeks, to refer them to your clinic? I'm sorry about the wording there.
Yeah, it's clear that it's safe to exercise someone after 3 weeks. That I think is clear. So I think the approach is safe, and sure, we'd be happy to see them if you'd like to, but it would be nicer if someone in your area could learn how to do the test, and therefore you wouldn't have to send them to Buffalo. But yes, it's definitely safe to do it in high school kids who've had symptoms more than 3 to 4 weeks. Now, I'll say that in younger kids, and by that I mean kids before puberty, maybe 11, 10, 9, I give them longer to recover on their own because literature suggests that they take longer to recover than adults. So I'll often give younger kids 4 or 5 weeks to demonstrate they're recovering. And if they're getting better, I just give them more time. But if they're not getting better, if they're stuck on their symptoms at 5 weeks and they're not showing improvement, then we'll use the exercise approach in them as well. High school, older high school, college athletes, 3 weeks is distinctly unusual for them to continue to have symptoms. But you also have to look at the trajectory. If at 3 weeks they're much better than they were at 2 weeks and things are going in the right direction, I'll usually give them another week to see if they clear up. And we might do a treadmill test just to determine that they're ready to return to play, but we won't start them on the physiologic exercise treatment unless their symptoms are just not getting better and showing that they're getting better at that point.
Thank you, Dr. Leddy. We do have about 5 minutes left. I have a few more questions that we have time for, and then if your question is not answered, I apologize, but please feel free to email it to me. My information is in all the emails you've been receiving from GoToWebinar, and I'll be happy to pass those along to Dr. Leddy. We did receive clarification from Ben. He asked, instead of a treadmill, what are some other options, I guess, if the mobility issues cause difficulties with the treadmill test?
Yeah, okay, that's kind of what I thought you meant. Well, you can try this on a bike, although it's a little harder because you have to measure blood pressure and heart rate. Although if you can set it up, a bike would be good because they're not actually bouncing around as much. But the same principle for a stationary bike would hold for the treadmill. It's just that we would have to develop a similar protocol on the bike because changing the resistance and the speed is different than doing it on a treadmill where you change the elevation and the speed. I've had people ask me if we could do it swimming in a pool, and again, the concept is the same. You just have a gradual increase in heart rate over time, but achieving that in a pool is going to be challenging to do it in any standardized way. So to answer your question, I think stationary bike is the way to go, but we haven't standardized that yet.
Thank you, Dr. Leddy. Another question I have, what are your thoughts on return to learning? There is no standardization. Should medical doctors require or mandate half days for a period of time?
Yeah, that's a good question because nobody really knows how to do that. And that's another area we're interested in because we have a lot of patients who have to attend school at reduced levels, and I think it really depends on how symptomatic the person is. If they really can't concentrate in class, then I take them out of school initially for a week even, and then see how they're doing, and then we'll work with the school, and usually we can have them start going back a couple of hours or half day and see how that goes. Some people need home tutoring for a while, and you may have to work with your school on a 504 plan. But yes, if you think that they can't handle school, then starting off with a brief time out of school or half days is the way to go. But nobody has standardized that either in terms of the best way to do the graduated return to learn process. It's very individualized.
Thank you, Dr. Leddy. Another question I have is, can a quantitative EEG be useful to assess cognitive impairment and changes in recovery?
I know there's been some research in that direction, and that's one of the quantitative tools that has been used, and I think if you have expertise in that area, then yes, use it. I myself don't have expertise in that area, and we don't use that. I know there are some researchers in the country that do use it. I don't know how commonly it's used in clinical practice, but I think that's an interesting area. It's another way to try to quantify brain damage and when that brain damage has recovered. I mean, other things that are coming down the pike are different types of imaging. One's called diffusion tensor imaging, which is probably going to supplant MRI at some point as the way to image people with brain injuries, we think. But that's a long way off. There are other modalities as well, but what people are trying to get at is trying to quantify what's going on in the brain rather than just listening to symptoms. So I think, again, if you have expertise in that area, it's something you can use, yes.
Thank you, Dr. Leddy. Another question I have is, for exercise after 3 weeks, even with symptoms, are you referring to phases 1 through 4 on the 6-phase return to play, meaning no contact or collision?
Yes. Yeah. We don't return them to contact or collision until they're able to exercise to near maximum heart rate and or exhaustion without exacerbation of symptoms. Once they can do that, then they can go back to non-contact practice and then full contact. We hopefully will be submitting some information on this using the treadmill test essentially to substitute for the first couple of phases of the return to play progression from Zurich. So, but that's a little bit down the road. But yes, that's the approach. You exercise first, and then prove you can do it, and then you go back to the other phases of practice.
Thank you, Dr. Leddy. Just 2 more questions here. For older students, when should a driver evaluation be obtained? After full recovery or before?
Well, that's interesting. There was a talk at the meeting we were just at down in Atlanta about that very thing, showing that early on after a concussion, driving is definitely impaired. But I wouldn't be surprised by that, and I would not do a driver evaluation until someone is recovered, or you think they're recovered. Doing it while they're still symptomatic is like taking a computerized neuropsych test while they're still symptomatic. You're going to have problems with it, but you just don't know why. So I wouldn't do a driving test until after the reporting their symptoms are down to, normal levels, and they seem like they're recovered.
Thank you, Dr. Leddy. The last question, and then we'll conclude our webinar for today. How do you determine when a student with a history of multiple concussions should return to play? Do you have a specific number of concussions when a student needs to be out of sports for good, or is it based on each student's specific history?
It's based on everyone's specific history, but the main thing I use is the student having frequent concussions that are happening more closely together in space and with less and less force to induce the concussion. So if someone has had, this is their second or third concussion this year with hockey, the first one, he got or she got checked into the boards and had a concussion for a few days and took a week to recover. Second one, it was a hard check. It took a little longer to recover. The third one was, they snapped their head back a little bit when they got bumped, and now their symptoms are lasting 3 weeks. That tells you they're losing their concussion reserve, and even if they can recover fully and can exercise, etc., that's when you have a discussion with the parents and the athlete about stopping that sport or stopping all contact sports. So it is an individual decision. It really depends on is the trajectory of concussions increasing? That is, are they happening more frequently with less force? I tell people there's no number, but we think that 3 may be an important number. But again, that's not known for all groups and all types of patients. What I'd be more concerned about is 3 over the past 2 years in a particular sport that the concussion is happening with less force and the recovery is delayed. That I think you have to seriously tell the patient to consider discontinuing contact sports.
Well, thank you, Dr. Leddy. This does conclude our webinar. Again, the presentation and the slides will be posted to our website, www.bianys.org. We thank you for joining us, and thank you, Dr. Leddy, for joining us today. If you have any questions or comments, please feel free to email me. Again, my email is in the automatic emails you will receive from GoToWebinar. And thank you for joining us. Please continue to check our website for our future webinars. And again, Dr. Leddy, thank you for joining us today.
You're welcome. Have a nice day. Bye-bye.